Welcome everyone to our final Tele-ECHO session for Stop the Spread Screen STI. So we've just been delighted to have you along for this quality improvement project. We're really happy to be able to share the results with you. We'll just check in to see who was able to join us today. We realize this is such extenuating circumstances, and we appreciate everyone who is able to join us this afternoon. So if we'll just flip to our participating practices slides. If you could just check in or say hello or put a message in the chat. Avocare Garden State.
Yes, Dr. Baker and Dr. Fitter are here.
Great. Asbury Park and Neptune.
Yeah, hi, Dr. Christina Atienza.
Oh, hi, Alexis Oram.
Great, thank you.
And you know I'm here too.
Yep, thanks, Dr. Wallach. Bridge Pediatrics.
Hi, Dr. Kumar here.
Great. Colts Neck.
Dr. Batista and Joanne.
Mute.
Welcome. Foundation.
Oh, they see me.
Okay. Global.
Yes, Dr. Gordon is here.
Great. Welcome. New Jersey Medical School, the ED and the clinic.
I'm here.
Great. Hi, Dr. Shahidi. Mahi.
Oh. Hi, this is Dr. Kaniki Charla.
Oh, good.
Good afternoon.
Great. Thank you.
Hi, how are you?
Wonderful. And
I'm mute, right?
Mahi, MD for Kids.
The Indian people, they have a weird.
MD for Kids.
I think this video is they can't.
And Neptune.
Oh.
Hi, Dr. Christina Atienza.
Oh, great. Hi. Monmouth. Anyone from Monmouth? And West Park.
Dr. Galperine is here.
Great. Thank you all so much for joining us. So at this time, we're going to turn it over to Carly Ryan from Central Jersey Family Health Consortia. And Carly's been working on our final results. So I'm going to turn it over to Carly.
Okay.
And please, Dr. Wallach and Dr. Northridge, our hub members who have guided this QI project all along, you're welcome to please add any commentary. Go ahead, Carly.
Hi, everyone. As Jean said, I'm Carly Ryan from Central Jersey Family. We are the contracted evaluator for this MOC program. So I'm going to be presenting the results of the evaluation, but I want everybody to feel comfortable discussing. I want it to be a discussion since we're all on the phone like this. So if you have any comments or thoughts, please feel free to pipe up and not feel that you need to wait until the end. So these are our two main objectives, was to increase the sexual health assessment of STI risk for females 15 to 24 years old by 30%, and to improve the screening rates for universal screening for patients 15 to 24 up to 70%. So we had a few different data sources, and I want to thank everyone for all of your work submitting both the cycle and the cumulative data. I know especially recently that's been a tough sell, but these are our different data points, and as we go through, I'll be presenting data from some of the different sources, so I wanted to discuss that. So thank you all who completed the surveys. We have the practice survey, which was a pre-program survey, and then the physician survey, which was a pre-post, which allowed us to look at things going on before and after the MOC program. Then we have our monthly QI data, which was the cumulative, or I'm sorry, the data that you sent on a monthly basis, and the time period for that was August through February. And we were essentially collecting just a few data elements, the sexual health assessment, sexually active, and screening. And we asked practices to submit 10 records per practice for that. For the...
Carly, excuse me, can you just lean into your mic a little bit more? We're having a little trouble. Thank you.
Yeah.
Sure.
Yeah.
Sure.
Yeah, I don't know if it's me because my Wi-Fi's gone.
All right. And then you also submitted at the end of the project the cumulative data, which was from August 2019 to January 2020, which was the entire patient population of females 15 to 24. And you guys had submitted some additional data elements allowing us to look at age, race, and screening results in particular. So these are the program demographics. Can you guys hear me better now, Dr. Wallach?
Yes, I didn't know if it was me because the Wi-Fi signal in this office I'm borrowing is a little weak, but I hear you now.
Okay, and Jean, you can hear me? Everybody can hear me? Okay, so this is just a look at where we are and who we are. So there was 13 practices total, 2 primary care pediatrics, 1 FQHC, 1 emergency department, 34 physicians, and in 4 counties in New Jersey. And you can see where they are. The practice setting, so you can see the proportion of practice setting. The majority of practices are 10 or in a suburban setting. We have 2 that were urban and 1 rural. So Dr. Wallach, I may ask you to chime in on this one. So this was asked pre-program. We asked, where was your STI testing performed before engaging in this MOC program? So we can see that at the time prior, so entering the program, nearly 42% of patients were referred to a clinic or laboratory. So that's our biggest group. And then we had about a third of practices who were doing specimen collection in the office. And then some other folks that were not routinely either ordering or performing them prior to engaging in the MOC. Do you have anything to add to that, Dr. Wallach?
Right, no, just that I think one of the learning points that we've all picked up throughout the project is that if we get the specimen done at the time of the visit and send it off, we had a higher testing rate. So I think that we should see the percent who started out referring patients to the lab actually collected it as a point of care in the office.
Right, and I think we're going to be looking at that for the final report too, looking at where testing was done and for practices that switched how they were testing or where they were testing, how that changed their ability to screen and get results for those patients.
Correct.
So this again was a reported pre-program. These are the barriers to screening that were anticipated prior to engaging in the project. So confidentiality issues we discussed from the very beginning were a big concern. The point of care testing, lack of point of care testing, as well as parent refusal, uncertainty of guidelines, not a high priority for the visit given all the other things that need to be done at a well visit, the time the screening takes, and some discomfort with discussion and assessing sexual health risk. Dr. Wallach, do you have any?
Yeah, I think that, I mean, yeah, again, clearly we identified early on that confidentiality was a big issue, and teaching the practices how to get a history from the patient without the parent in the room, and different tactics that we each, shared with each other. So again, I know that I will have gotten better. And again, the do not have the testing in the office, everyone learned we could get the specimen cups directly from LabCorp and other labs that we use. And I think we had less parents refusing once we explained about what universal screening was. So basically, I think this makes sense.
Yeah, and I think a lot of those early sessions that you guys did focus on these types of issues really helped move things forward and move beyond those barriers.
Yeah, I think this also just goes to, it's Dr. Northridge, why universal screening is so helpful, because you don't have to worry that parents would expect there to be that test. So you don't have to worry about breaches of confidentiality in any way, because the parents are aware that the test is being done.
Okay. So looking again at our physician survey where we do have pre-post data, you can see the slide on the left shows the pre-post responses for how comfortable the providers were at assessing sexual health and having sexual health discussions with their patients. So we actually have a 14% increase in those reporting that they felt very comfortable between the beginning of the project and the end of the project. We also do see that we have some folks on the post who were very uncomfortable at the end of the project, and we didn't have anybody at the beginning of the project. I had some thoughts about why that might be, which was that when you all engaged in doing this process, for those of you who weren't currently doing it prior to the start, you found that you had more discomfort than you anticipated or were aware of at the beginning of the project. But I would also leave that open for feedback too, if anyone has any thoughts on that.
I don't know if anyone else wants to speak up about that, but that, I mean, that does sound like a logical assumption, right? If you weren't asking the questions before and now you're starting to ask them, you might realize it's a little bit difficult to ask these questions. So.
Right, right. So on the chart on the right, we also have pre-post data for how often the sexual health assessments were conducted for our target population. So again, we see pre-post. And we actually have an increase in just about 30% in always, which obviously goes along with the universal screening and is wonderful. And then we see a little bit of decline on the sometimes and often because those practices shifted over to the always model.
Great.
So this one again, physician survey, we have time spent alone with the patients without the parent present, pre and post. The green is pre and the post is blue. So again, we have a big jump here in the always. So we see a lot of practices have started and implemented a policy and stuck to it in terms of always spending alone time with the adolescent, getting that valuable time to speak to them without their parent present.
Yeah, we spent a lot of time discussing the importance of alone time and the barriers to that. And it's great to see the shift towards alone time. And so the chart on the left is the individual physician, and the chart on the right is the practice adopting a policy of alone time. So it was great to see some improvement on both the individual physician as well as the practice level.
Can you remind me, did this question specifically ask like time alone spent with patient during well visits, or was it like for any visit, like including sick visits?
It was well
I think
visits.
it was well visits, yeah. Yeah. So, and again, looking at the chart on the right, you can actually see that over half of practices reported that they already had a policy about alone time. And that when you add together those that had a policy with those that already adopted it but are considering it, the vast majority of practices, nearly 90%, are working on a policy or have a policy for time alone without the parent. Okay, so this is the STI approach, or STI screening approach for female patients. So we had asked on the physician survey what most closely represented your approach to STI screening, both before and after participating in the MOC. And I apologize, the colors are flipped. So this one, blue is pre and green is post. But importantly, by the end, we see that nearly 70% are have adopted universal screening to females 15 years of age and older. And then we still have some that are doing some risk-based screening by the end, but dramatically less. And then we see some folks are reporting that they have something that was a little different than all of the questions asked here. So this is looking at the monthly cycle data that you guys had provided. And this is the sexual health assessments conducted. So this looks similar to the run charts that you received for your own practice. So we actually started very high at baseline here. So we started out with nearly 78% reporting that they were doing sexual health assessments routinely, and then we ended at 87.4%. As a little bit of extra information, every practice that participated was either started at 80% or higher or did meet our 30% goal of increasing the sexual health assessments. So that's great.
And just to specify that this run chart is for the well visits only.
Yes.
And that the project expanded to the ED as well as some applicable sick visits. So all those efforts are well appreciated and are included in the final report document. But for purposes of the original objective, we're showing the female well visits. And I know some others had even expanded to some of the male screening for males. So it was wonderful to see the project expand as we went through. But these are focused on our target population.
Correct. And actually, now that you mentioned that, Jean, if you were to look at this compared to your run charts, the numbers would be a little bit different because we did manipulate the data a little bit after we were able to pull those sick visits out. So this is the same thing for STI Screen performed and offered. So one thing that's interesting, so some practices submitted data where I was able to determine that they tried to screen, but either a parent refused or the patient had been screened within the last few months. So if I had that information, I could recode those as screened because you guys had tried. But we didn't have that data for all of the practices. So if we had had that data, we may see our numbers actually go up, but that was not a required data field. But there is a 24.5% increase between cycles 1 and 6, and we had a big range between practices in terms of progress. So we have some practices that struggled, and we have other practices that, you know, moved to 80, 90, 100% screened and had a rate of improvement of, you know, around 80%. We did, and I think we talked about this on one of the prior calls, we did see a little bit of a decrease in cycle 6. And I think we had talked about that a little bit on one of the calls, but just something to keep in mind as you think about your own data and your own workflow and what might have been a difference between December and January in your own numbers.
Yeah, and the other thing I was just gonna say about that is that a lot of, you know, when we were asked, you know, to submit, what we were asked was it performed or offered? So, you know, once we got the results back on our raw data, you know, we would know if the patient actually went, because, you know, for the ones that weren't done in the office, for example. So they still counted as being offered if we ordered the test for those that didn't even get it done. But, you know, just, you know, to make that point is you still got credit for doing the screening, even for the ones that weren't done in the office.
Right.
Yeah.
So we're going to switch gears here to the cumulative data, which is a more representative sample of the patient population, because these submissions were all of the patients that fit the criteria, not the sampling of 10 per cycle. So you can see the number of records we have, the number of sexual health assessments. We had 21 positive screens for the, of the 393 patients that were screened. So these are overall average numbers during the course of the MOC. So these are not a time point. So overall during the project, 82.7% were assessed and 51.5% the screen was performed or ordered. Sorry, I'm on a computer with 2 screens and the screens are the reverse of what they normally are. So my mouse and I are tangling. So these are the cumulative data findings. So 2 of the pieces that we had asked for to look at was race and age. And we'll look at some of the information broken out by age. So the biggest age category, 86% of the patients were 16 to 20. So nearly half of the patients were 16 to 17 and another 31% were 18 to 20. So we did have we had quite a few 15-year-olds actually, and not very many of that were 21 and older. So also when you look at the race and ethnicity, you can see the distribution there. And just in terms of a point of comparison, because the minority, Black and Hispanic groups are overrepresented. So I just pulled Monmouth County data, since a lot of you are in Monmouth County, and the rate for African-American or Black in Monmouth County is 7%, and we actually see 30% in our sample, and for Hispanic, it's 11%, and we see 21%. So that really speaks to your patient population. So this is looking at one of the things that had been discussed from the beginning was whether age and being a minor and issues of insurance and other things might factor into whether someone who participated was more, or a participating practice was more likely to screen those that were less than 18 and assess them versus those that are 18 and older. And you can see that definitely those 18 and older were more likely to get a sexual health assessment and an STI screen. So in terms of the results, this is the breakdown of results information that we have. We do have a fair amount of pending or unknown, but for the vast majority, 310 of the screens, or 75%, were negative. We did have 5.1%, or 21, who were screened positive. And of those who were screened positive, we had 3 that had not disclosed that they were sexually active. So if you look at the number of positives, and you look at our number who did not disclose that they had sexual activity, actually 14.3% of our positives that were identified through this program would not have been picked up without universal screening.
I think that's a really good point.
Yeah.
You know, to speak to why universal screening is important.
Absolutely. And if you think about, you know, the overall looking in the 50s to 60s for screening, and if you were to extrapolate that to higher rates as practices continue to work on this, those numbers will go up, I anticipate.
And like the overall positive rate, so like so it's like almost 7%, right? Of the 21 divided by 310, like of those we have results. And I think that's fairly representative of the state.
Mm-hmm.
So it's like a fairly representative sample.
So this is just to look by practice. The practices are de-identified, but to look at how practices did in terms of sexual health assessment. And again, this does not show change over time. It just shows a median of what happened during the entire project. And I think I mentioned earlier that by the end, by cycle 6, everyone was meeting the goal of increase or doing those sexual health assessments. So that was definitely a big success with the assessments. Oops, sorry about that. My computer's.
It's okay. Oops. It's went a little fast.
I was gonna say I'm going the wrong way here somehow.
Oh, there you, okay, the next one, yes.
There you go.
Okay, and then this is the same thing looking at the screens by practice. So again, there was a pretty big range between how practices did with this and what challenges that each practice incurred at different points throughout this 6-month project. And I think Dr. Wallach is going to talk a little bit more to this at the end, but you can see, so one practice has been screening, you know, across the life of the project 100%, and another one 93%. We have some practices that actually increased by close to 90%, and others that did have a little bit more trouble meeting the goal, and some others that made progress but then had decreased a little bit. And again, looking at that cycle 6, we do see some decreases there. So these are some from the post-physician survey. We had asked what changes in practice you guys had made as a result of participation in the program and to help you implement the screening. So these were some sort of high-level grouped things that different practices had reported. So obviously implementing the universal screening, switching to the in-office collection. Saw a lot of systems and process changes that included forms, flags, EMR updates, patient brochures, all sorts of things of that nature to help move along the process of implementing and make the workflow work for the practice. We saw just a lot of increased verbal patient education in addition to the written, a lot of improved sexual health assessments, expand who sexual health assessments were conducted, so expanding from a certain age to all adolescents, incorporating EMR changes, things, flags, reminders, different things like that to help folks remember, reporting universal urine collection at the beginning of a visit so that the urine was there no matter what, And again, sort of moving the changes to other populations. As we had discussed, we have the one group who had expanded to some sick visits. We have the emergency department. So taking a look at, and there'll be more data to speak to this in the final report, taking a look at how this could be implemented in other arenas other than well visits. Here's some additional ones. So some of the programs that didn't, or practices I should say, that didn't have alone time, initiated that. Increasing awareness of the need to screen among parents, among staff. Improving their screening or tweaking their screening to those that denied sexual activity. Patient follow-ups and referrals, collecting cell phone numbers of patients treated, which is wonderful in terms of sharing results and things. Improved questioning of sexual orientation. One practice partnered with a free adult STI clinic and was able to give referrals to folks. Daily huddles in the morning. So these were all things that practices reported changing that helped them to move towards the universal screening and towards our goals. So looking at sustainability, we had asked you guys some questions on the post survey in terms of your intentions to sustain the changes that you made. And so one of the questions was, if you adopted universal screening as a result of the participation in this program, and we have more than half that said yes, they have adopted it, and 26% said that they haven't, but they're thinking about it.
And just a reminder that this is on a practice level. So
Okay.
while we have the individual physicians adopting universal screening, this question was asked about, did the practice change? So did the practice adopt a standard? So that was very encouraging.
Yes. And then by physician, we asked also if they plan to continue the universal screening after the completion of the STI, and overwhelmingly almost everyone reported yes. And I know there's going to be some more talk as we go, but that is the end of my slides. Does anyone have any questions for me? Well, thank you for listening, and thank you again for the hard work you did submitting the data and getting things to us so that we can look at how the project has done, which is actually really very well. So thank you.
Thank you. Yeah, and thank you for all your hard work and for helping us analyze our data, because I know we'd be lost without you, so thank you.
Thanks so
Dr.
much,
Wallach.
Carly. All right. So Dr. Wallach?
Oh, okay. I don't know how to advance the slides because I still only have it opened on,
We can advance for you. There's only a couple slides left.
Yeah, it's only just this. Yeah, I mean, basically, this is just a run chart showing sustainability. So the first data point is the baseline point, and then every cycle data. So September, October, November, December, January, and then the last one was post-January data. So you can see that even after the official end of the project, this is a sample one of my practice, but that we still maintained, doing the screening. Now, unfortunately, we're all suffering through this difficult time with the pandemic, and so as a result of that, all of us, I think, at least I can say for the Hackensack Meridian family, have paused on well visits for children over the age of 2. So therefore, we won't be currently screening any 15-year-olds right now. But we're hoping that, as those things change and we start to rehab our adolescents back in the office again, we don't want to lose this momentum that we have developed over time. And, because when you look at what makes quality improvement projects sustainable, it's, a lot of it is enthusiasm, having a champion, but more than just the champion is having created a team-oriented response to the project, so that if the champion, Dr. A, that was a champion, isn't there, that, for whatever reason they're on vacation, that the other doctors who are there and providers will be able to still do the project and keep it going. And you need to have buy-in basically for that. And if, they do talk about administrative support, if it's something that costs, money. Luckily with our project, even the specimen tubes were all given to us, without cost from the lab. So it's more just, huddling and knowing, okay, how many well visits do we have today for 15 and above? Let's make sure that when they come, we have a urine cup ready for them, and, having the script on how to get the parent out of the room, and then having the script with the patient explaining what universal screening is and why it's important, and letting them know that, yes, they still can opt out, but hopefully they'll see the benefit in getting the screen done over not getting it done. And so therefore, luckily for us, like the cost part is low, so we should be able to maintain it, provided we're able to have the children in the office. Although now we're talking about converting things to telemedicine, so we could do. And we even talked with Dr. Brill on our last hub call about this. How are we going to do a confidential encounter over the phone or over the video camera? So basically, it would probably be this, and I don't know if Dr. Northridge wants to jump in, but I think that, we would probably do the same thing. We would try to find a space, hopefully, where the child would feel comfortable having the parent step out when you conduct the visit. And the same, confidentiality rule applies, that we wouldn't tell the parent what's discussed without their permission. I don't know if Jenny, if you want to jump in on that, if you have any thoughts about that.
Yeah, I think so. It's something that isn't done a lot in adolescent medicine. I asked some of my colleagues, during this pandemic, some of my colleagues have been doing this more. I'm on maternity leave, so I'm not doing anything. But
yes, congratulations.
Thank you. I'm just being honest. I haven't done any medicine in 5-6 weeks. And everyone should time their maternity leave with pandemics. I'm just joking. But so that's what my colleagues have done, for instance, at Montefiore, that they literally just ask the parent to leave the room, and part of the visit is just with the adolescent. I think it's a little bit harder to ensure that part is confidential, because normally in your clinic you can make sure the parent isn't right outside the door. But you can't as much when you're in a house, and obviously people have different places where they live. Some people live in very small apartments, right? Some people have crying babies, right? There's different constraints. So I think it's harder, but I think it's important, even when you do telehealth, to keep in mind that the top morbidity and mortality for adolescents is everything that's confidential, right? They die from accidents, number one, disproportionately related to drugs and alcohol, homicide, suicide. So it's all the things that we get on our confidential history, in addition to the importance of sexual health assessment and STI screening. And at least I guess that also goes to, if you do universal screening, even if you don't get that they're sexually active, you're at least screening them for gonorrhea and chlamydia would be important. I think the other thing that I find really important is that in the comments, a lot of people talked about systemic changes that they made, right? Changes in their EMR and things like that. So it's not just on the one physician after the pandemic to keep it in their mind that, right, there's triggers in the EMR, as you mentioned, Dr. Wallach, that the whole team is involved with the huddle, right? That with the urine collections, it's the front desk staff, so it doesn't just fall on one person. But these systemic changes are even more important when there's a pandemic that sort of alters your momentum. So I think that's really important.
Right. I mean, it's interesting that we literally finished our project, in time before this unfortunate thing has happened, and we don't really know what the immediate future holds about it. But I do think that we have to think about ways to take care of people, because there are a lot of other diseases and just the things you listed, depression, anxiety, which then could lead to substance abuse and suicide. And maybe, I know they're not supposed to be seeing each other. I don't know if social distancing is going to decrease STIs or not.
Right. There's people who think there's going to be an increase in pregnancy and STIs because no one's getting put on birth control, or I'm not placing any IUDs. But yeah, and then there's other things, right? People worry about child abuse really skyrocketing, right now because there's no like teachers, nobody's like seeing people who are in vulnerable situations, right? Like how domestic violence might increase, child abuse. Anyway, there's things that are very sad, but we can't talk about it. Yeah.
So because one of the other things was regarding consent. I think that if we get the initial telemedicine consent that we get for the encounter at the beginning, just like we would in the office, we don't have to get a separate, right, confidentiality consent from the patient. Does that make sense? You know, because that was something we weren't sure of from like
yeah, I think that makes sense. That you don't need like a separate consent for like the teenager. That's not how we conduct like in-office visits. So it wouldn't make sense that it would be different for telehealth. It has been a question that like was sent to like all adolescent medicine providers, like, is there a separate consent? And everyone I know doesn't have a separate telehealth consent. So it's
Thank you so much for answering that question, because we unfortunately weren't able to talk to you on the last hub call, and Dr. Brill also the same way, that there was not a separate, because just like you said, in the office, we get the initial consent when they register and walk in, and then we just, you know, tell the parent and the child that part of the visit will be conducted all together and part with just the adolescent. So thank you, because I think a lot of, I don't know, well, we can open it up to the floor and if other folks want to speak up about it, but I would think that would be something on people's minds as they're trying to, you know, we don't want to forget about our patients in the practice that are over 2 years old, you know, so.
Yeah. So yeah, like just like for gonorrhea and chlamydia screening, for instance, even if there was a practice out there that did a risk assessment method, for instance, or, you know, like let's say it came up in a sick visit that someone was calling, complaining about pain with urination, right? Like as opposed to like how we've been doing universal screening. Just as it is in the visit, you don't need like a separate written consent to do a gonorrhea and chlamydia screen, right? Okay. That like the teenager can just give verbal consent and you can send them.
Right. And I think it's important, as Carly brought up too, one of the points that we implemented was getting the adolescent's cell phone number and putting it somewhere in the EMR or paper chart, if you have paper chart, so that you can call them directly with the results when you get them.
Yeah, hugely important. This, by the way, also comes up inpatient sometimes that, you know, because gonorrhea and chlamydia testing takes like 3 days to come back. Well, it depends on your practice, but a lot of places will, even as we're expanding, you have to think about that as we're expanding gonorrhea and chlamydia to other venues. Like, right, you have to have the thought, like if you're doing it inpatient and it isn't resulted, you need like the teenager's cell phone. So like, yeah.
Yeah, and yeah, because that's true. Because I wonder if, you know, those practices that have residents too, right? If they're used to doing that when they have a child that they admit for asthma, say, but they are also sexually active, and you know something else comes up.
Yeah, it's one of my big teaching points. Asking them when they last had sex, do they need Plan B? Like doing that first, right? Like these are the things I care about in life. But doing her depression screen and cell phone number, yeah.
That's great. Mm-hmm. So, you know, the next slide is just on reflections. So, you know, everybody, maybe we can open it to the floor. Jean, right? What do you think about what everyone thinks their strengths were, anything they think they need to improve upon, you know, and how they can do that? Jean, do you want to open up to the floor?
Yeah, certainly. We'd love to hear from all the spokes and, you know, your thoughts on participating in the project and what you plan to do to keep it going. Any thoughts?
So for us, I think it was very eye-opening experience. We recognized that we knew it was important, but we recognized that we are not doing a lot of it. And the problem was that a lot of our clients are not coming in specifically with anything related to the sexual questioning and other things. But everybody now in our group has agreed that we are going to make this one of the priorities that we are going to have, and we are going to move toward implementing a universal screening. We have to convince a lot of people in the institution and in the hospital and medical school. But we have recruited a lot of our residents are interested in it, and some of them are just in the first year and the incoming group. So we are hoping that within a year or two, we can actually move into universal screening. Everybody who comes in 15, and we are going to expand it to males as well. So we can have that. It was a great project. I'm a public health physician, so I fully endorse everything that is related to public health. So that was our take from the project.
Thank you so much for sharing that. Thank you. Anybody else want to give us some feedback?
Hi, this is Dr. Kaniki Charla speaking. This has been a great project for us, and right from the beginning actually, because we learned one thing is that we learned to be consistent with each of the patients, and we learned to be consistent at 15 years and above, any girl who comes for a well visit, that we're going to do. And then we slowly started implementing the similar questions into even sick visit patients, because it's very hard for the teens to come to our office, and we really didn't want to miss them, not just during the well visit, but we wanted to make sure that we do it in sick visit or any time that we catch them. And the other thing is that we incorporated a lot of questionnaire, anticipatory guidance, education material into our office. We started printing material and putting it in the patient exam room also, so that it would be easy handout for the patients. And then we never actually did urine testing for STI in the office, and which is something new to us, and it's a new educational tool for the entire staff and us. And we also started learning to make small huddles, making small meets, 5 minutes, 10 minutes, once a week or 2 times a week, or based on our availability of time. It is not just for the STI, but it started bringing a lot of strength and confidence in taking care of patients in the office, to bring people together, to bring the staff together, to make meetings and to implement the tools, to educate our staff, which I think that we were not that strong before, or we were doing it, but without these small huddles or meets. Every
Right.
small thing that we made is useful. And then I really thank the entire NJAAP team for helping us during this for this project, and also to maintain it and to constantly keep calling us and making sure that we are doing it or not, that you didn't get the data. And I'm very sorry that sometimes things went a little bit slow, but you were always there to help us and to work as a team. Thank you. I really appreciate from the entire team from Mahi Pediatrics. And it was a great project for the patients. Actually, we improved a lot of treatment wise also, and they were very happy, the teens.
Thank you for that feedback. I think that it really highlights what quality improvement is about. Like when you talked about working with the team members that you work with every day on like a different level and educating them, in an organized way, it kind of highlights like how this is a relevant way of doing research. It's a different type of research, but it's and how it can lead to improvement and change. And so thank you so much for those comments, because I think they highlighted a lot of reasons why we create these types of projects in the first place.
That's true. Thank you. Thank you so much.
Thank you.
Thank you very much for your active participation, and so thankful for that feedback. Yeah. We have just a few minutes before we do our final announcements. Would love to hear from another practice. Your thoughts?
Also, I just want to add this is again Dr. Kaniki Charla. We the first 2 weeks we stopped doing well visits at all completely in the office, but with the telemedicine we are able to implement this questionnaire also. We are doing well visits for babies, for children, and while doing the well visit with the telehealth, we are able to ask them these questions. So, but we are not able to pull up enough data because we have not been able to make a log sheet, and also the patients are not able to go to the labs. So either way, we are able to implement the questionnaire, anticipatory guidance, and see how they're doing. Just a small note for
Yeah,
that.
that's interesting. Thank you for commenting on that. So you are conducting well visits, not in the office for older children, and you're doing all the anticipatory guidance and everything with them?
Yes.
Just without examining, with just no exam, right? No
Yeah, with
physical.
no exam, but it will be like a video session through our EMR, and still we can get a lot of information. That way we are not actually missing, but we are telling them, okay, we are going to still see you in a couple of months in the office once this is all over.
Right. Okay. Thank you for sharing that information.
Thank you.
So hi, this is Dr. Rugani Shah. I also want to thank AAP for this excellent chance to do this project. Such an eye-opener, such a simple test, but it goes to treat and help teenagers in the longest way possible. Simple message, but a life-changing message for the teenagers. And it's surprising how all these years we never thought of doing something so simple, such a non-invasive test. Gained a lot of information. You know, I think my weakness was always how to approach patients and the parent with this topic, and this kind of, you know, just going through this all these sessions with you all made it so much easier and approachable. You know, learn ways on how to approach the families with this issue. I think the strength from this project that we have gained in our practice is that routine testing of the urine in the office, where we have them collect the specimen and it's sent out. And, you know, fortunately, the patient population has been very receptive. 9 out of 10 times we've been successful in getting the specimen and have been able to send them out to the labs for them. I think the convenience of doing it in the office for the family is also a plus point. And, you know, I second everybody's voice that we really gained a lot from this AAP module, and hope we can do something like this in the future for other topics. Thank you.
Thank you. That's great. Actually, one of the questions I wanted to ask, but we couldn't do it in a poll, was does anyone have any ideas on future projects? So if you have any ideas, email Jean or email me, anybody, let us know.
Yeah, we will have some recruiting opportunities when this pandemic settles down. So we'll be reaching out. So thank you. Well, should we move on to the next slide, Charlene? So thank you all again for your participation, and you will earn your MOC Part 4 credit. So Charlene has the instructions for that. Basically, you're just going to log in to the website. Look for our specific chapter, New Jersey chapter. There are other chapters that might have a similar project, so make sure you get the New Jersey chapter, and the name of our QI project, Stop the Spread, Screen STI. Just flip through the questions and then email Charlene back. And then we will go into the system. Once we get your email, we will go into the system and attest for you. And the attestation happens very, very quickly. So you will have that in your account almost immediately. So if you can all please go into, log in to the site and do your attestation by April 27th. then we can make sure we have everyone signed off by the end of the month. Any questions with that process? We'll send this out in the follow-up email.
Yeah, I was just gonna say, if you didn't take a screenshot of this slide, we'll all get, we'll all get the credit information. So
It's
like you'll email it out to everybody, you said? Also this slide? Okay.
Yeah, and it's really fairly easy to go through. If you log in, you just have to locate our chapter and the name of our project and sign-in date.
Okay, great.
Okay. Thank you again for a great session. Thanks to our hub members, Dr. Wallach, Dr. Northridge, and on behalf of our lead hub member who was not able to join us, Dr. Brill.
It's Passover. Yeah, it's still Passover. She observes, it's I think it's almost the last day. So it's usually the first 2 days and the last 2 days. So she unfortunately wasn't able to join us, but she sends her thanks and everything.
Absolutely. So thanks again. And stay safe and enjoy the rest of your day. If you have any questions, feel free to respond via email, and please take our very last survey. Thanks so much.
Thanks, Jean.
Thank you. Stay safe, everybody, please. Yeah.
You too. Thanks, Dr. Wallach.
Thank you.
Bye-bye.
Bye, everybody.